Very good afternoon, respected panelists and respected audience and senior and junior colleague. Welcome to Everyday in Young Cardiologist panel session. My topic is Misfortune Never Scam Alone. This is the aorto coronary dissection. I am Dr. Partha from Assistant Registrar Cardiology from NICVT. Case, Mr. X, 46-year-old gentleman, having cardiovascular risk factor for hypertension, diabetics and smoking, presented with ischemic chest pain for 6 hours, and he was diagnosed as an inferior ST elevation MI and treated with initially thrombolytic. ECG shows old MI inferior, and echocardiogram also reveals hypokinetic inferior wall with LV ejection fraction near about 50%. And coronary angiogram done, and it shows left main normal, LAD mild lesion in the mid part, and LCX 30% stenosis in the mid OM, and RCA 99% stenosis in the proximal part of the PDA. And the procedure was done. Initially 6-pen Judkin right 3.5 catheter was engaged in the RCA, and Terimo run through floppy PTCA guidewire in part in the distal part of the PDA. Pre-dilatation done with the 2 mm into 12 mm semi-compliant balloon at 8 atmosphere. And this is the view of RCA after P-dilatation. And 2.25 into 30 mm Jotarolemus eluting stent was deployed at 10 atmosphere in the PDA. During the deployment of the stent, radiological feature of dissection in the proximal and mid part of the RCA was evident. And at that time, patient hemodynamically also get compromised, and after PDA stenting, dye held up in the ostium. During the PDA stenting, dye held up in the ostium, and dissection flap in the proximal part of and flow compromise in the distal part of the RCA. Dissection of the RCA extend into the ascending aorta, creating type A dissection, and patient became hemodynamically compromised. To prevent the further extension in the ascending aorta, we first deployed 3.5 into 40 mm or sirolimus eluting stent in the osteoproximal and the mid part of the RCA at 12 atmosphere, and another stent 3 into 4 mm or sirolimus eluting stent deployed in the mid and distal part of the RCA, overlapping the proximal and distal stent at 12 atmosphere. After completion of the procedure, patient was hemodynamically stable and angiographically showed no further extension in the ascending aorta, and upper flap of the aortic dissection also disappeared. During PCI, unfortunately simple procedure may turn into more complicated scenario involving the dissection of the whole RCA and LAD, including the ostium and ascending aorta. We took every attempt to occlude the further retrograde extension into the ascending aorta by deploying the non-cover stent across the ostium. So good control of the retrograde flow was obtained, and the dissection of the coronary ostium always a emergency procedure. Ostial dissection of the right coronary artery is more common than the left main dissection, and it happens more frequently from radial approach by using AL1 catheter, and the responsible factors are inadequate alignment of a diagnostic or guide catheter and forceful injection of the contrast medium. And this dissection also defined as a class 1, class 2, class 3 involving of the aortic caps and its extension into the ascending aorta below 40 mm or above 40 mm, and the frequency of aortic dissection is about 0.7 and 0.02% for PCI and diagnostic catheterization respectively. All iatrogenic dissection can be treated successfully either by ostial placement of a cover stent or conservative management, and other author also advocate the use of single or several non-cover stent also. From a practical point of view, placement of the cover stent should be attempted if technically feasible to seal the entry of dissection and stop its progression. And the take-home message, aortocoronary dissection is a rare but life-threatening complication. Management of the dissection propagating to ascending aorta is a really challenging. Rapid recognition is essential to save the life in a proper manner, and prompt treatment with conventional non-cover stent for aortocoronary dissection, it became also life-saving sometime. and it is the deep condolence for the recent flash flood in our country. And we finally acknowledge Professor Dr. Amol Kumar Chaudhary sir for kind cooperation in this case management. Thank you.